Dear friends, it is a great honor for me to speak today on the topic that has been assigned, which is the central role of the liver as a determinant of metabolic health at this auspicious meeting. Here are my disclosures. The central theme for my talk really is to discuss the evidence that involvement of the liver in the context of metabolic health leads to development of a condition that we know as metabolic dysfunction associated steatotic liver disease, or MASLD, and it plays a central role in driving outcomes for the heart and many other organs. A good place to start this conversation is to get on the same page in terms of definitions. Pathologic accumulation of fat in the liver is known as MASLD. It has two principal histological phenotypes. This is a condition that was originally described by pathologists. One phenotype is where you just get steatosis, and that is known as MASL, or metabolic dysfunction associated steatotic liver. And the second lesion is steatohepatitis, or MASH, which includes three principal components: harmful steatosis, lobular inflammation, and a form of hepatocellular injury that we call ballooning degeneration. So the reason we make this distinction is because steatohepatitis can progress to cirrhosis more frequently than a steatotic liver. And there are two critical concepts. One is the disease activity, which is basically the steatosis, inflammation, and degeneration that reflects the disease process. And the other concept is fibrosis, which is a consequence of disease activity and leads to cirrhosis. It has now become apparent that cardiovascular disease and MASLD share common risk profiles. Up to 82% of patients with MASLD are obese, and 71% have full-blown metabolic syndrome. Type 2 diabetes is present in 44%, and similarly, there's a high representation of chronic kidney disease and dyslipidemia. Conversely, you also see that about 68% of patients will have hypertension, and coronary artery disease exists in almost 45%. So these conditions frequently coexist. So the question is, are they just true, and unrelated, or does the liver actually play a role in driving these other diseases? So in order to interrogate that question, let's look at epidemiological data, clinical data, and some biological data. So what you see over here are data from the Centers of Disease Control from the US. And in the US, you see there are three waves. The first wave is the obesity. The second is, in those days it used to be called NAFLD. And then the third is diabetes. So basically, the fatty liver is upstream of development of diabetes. Okay, so now moving on to the clinical data. We know that patients who have excess fat in the liver are more likely to experience a variety of cardiometabolic outcomes, even after adjusting for other covariates. So, for example, if one looks at MACE, after adjusting for other covariates, the hazard ratio is 1.4. And for type 2 diabetes, it is 2.6. Similarly, there's increased hazard ratio for CKD and even Alzheimer's disease. So having fat in the liver is an independent risk factor for the development of all of these cardiorenal and metabolic outcomes. Now, particularly, one of the things that is important from a cardiovascular perspective is the development of vulnerable plaques, which are characterized both by stenosis and the development of necrolysis within the atherosclerotic plaque, which appears as hypodense regions in a coronary angiogram. And if you have both, your risk of having a coronary event is much higher than if you have neither. Now, what we now have seen is that uh, this is probably the first paper that showed this, that in patients with NAFLD, plaque remodeling and lipid core plaques are much more represented. And we have also published this in the setting of patients coming for evaluation for liver transplant, where every patient gets a cardiac cath, and patients with NASH seem to have a lot more cardiovascular disease than other etiologies of liver disease. Furthermore, if one looks at heart failure, these are data from Europe, and they show that the cumulative incidence of heart failure is much higher in those who have excess fat in the liver, and it is not due to heart failure with reduced ejection fraction, it is due to heart failure with preserved ejection fraction, as shown on the right. Furthermore, even when you look at atrial fibrillation, the cumulative data suggests that it may be increased in patients with MASLD. Now, moving on beyond just the heart, if you look at vascular health, in the NIH MASH Clinical Research Network, we found that the incidence of hypertension really was a function of fibrosis stage in the liver. So for stage 0 to 2, the incidence was 6.5 per 100 person years. But when you got up to stage 3 and stage 4, it really shot up, and compare this to the general population incidence of 5 to 8.5%. And we have early data that if you just target the liver and you treat the liver without affecting the surrounding obesity, insulin resistance, and other factors, and this is done with resmetirom. These are early data with resmetirom, which we presented at the annual meeting of AASLD last year. We see already a decrease in the incidence of hypertension. This is, of course, very early data. I would not take this as gospel yet. It needs to be validated and independently confirmed by several groups. But this again goes to show that liver may play an upstream role in the development of vascular health and cardiac health. And if you look at the kidneys, again, those who have MASLD have a much higher rate of development of chronic kidney disease. And in our NASH CRN data, which is a highly phenotyped population of patients with MASLD, once again, as you progress from stage 0 to 2 to stage 3 to stage 4, the risk of developing chronic kidney disease and experiencing a 40% or greater decline in EGFR continues to increase remarkably in an exponential manner, again supporting the idea that the liver is playing an upstream role in the development of these outcomes. So let's see what we've learned. We showed the epidemiologic data, and we have looked at clinical data linking MASLD to vulnerable plaques, increased MACE, increased atrial fibrillation, increased CKD hypertension, type 2 diabetes. Also, incidentally, the more metabolic features you have, the more likely it is that you'll experience a liver outcome. So there's crosstalk between these organs that goes on as well. Now let us consider biological events that link the liver to metabolic comorbidities. Now, many years ago, our journey with MASLD started when we noted that a lot of patients were coming to our clinic with fat in the liver, and we didn't really have an explanation for that. And it struck me that all of the patients I had seen were obese and diabetic, which led me to develop a hypothesis that this was linked to insulin resistance, which, as you know, is associated with increased lipolysis, and it's driving fat into the liver. So we tested this hypothesis by doing insulin clamps, which is a test where you infuse glucose and insulin till you're at steady state with both glucose and insulin levels. And the amount of glucose you have to infuse per unit time is the amount of glucose that is being transferred from the extracellular to the intracellular compartment. So the more insulin sensitive you are, the more glucose you have to infuse, the more insulin resistant you are, the less glucose you have to infuse. So you see over here that you go steadily from control to MASL to MASH. It is a progressive decline. And this link with insulin resistance is what led to the connection with diabetes, eventually cardiovascular disease, and even is the basis for much of our therapeutics today. So at the same time, we noticed that the mitochondria in MASH were very abnormal and was associated with loss of Christie and development of paracrystalline inclusion bodies and marked increase in oxidative stress, which is a key factor in the liver disease itself. Okay, so the delivery of excess fatty acid due to peripheral insulin resistance also is associated with impaired glucose clearance in the insulin resistant state. So you have two different substrates arriving in the liver, fatty acids and glucose. Now, the changes in adipose tissue in the insulin resistant state lead to release in inflammatory cytokines. They are also microbial drivers. In the liver, they produce a metabolic overload. And so the liver cell has to turn on all its metabolic machinery to deal with substrate overload, producing damage to this machinery that triggers activation of inflammatory responses. If the damage is enough, leads to stress responses and kills the liver cell. Liver cell death further generates inflammation, and together they promote fibrogenic remodeling, eventually culminating in cirrhosis. Well, all of these pathways have also been implicated in the genesis of CKD, HFpEF, and even islet loss. So there is a lot of shared biology that further links the liver to all of these other conditions, and they're all linked to underlying adiposity and insulin resistance. Now, from a mechanistic point of view, atherosclerosis is driven by cholesterol and to some degree triglycerides, and much of the body's cholesterol load and triglyceride load is made in the liver. So that's almost 80% of the body's cholesterol load comes from the liver. So in the liver, acetyl-CoA through these two transcriptional factors, SREBP1 and SREBP2, lead to increased triglyceride and cholesterol synthesis. And that's linked to HMG-CoA reductase, which is the rate-limiting enzyme for cholesterol synthesis. And together, essentially, this excess triglyceride and cholesterol are packaged as VLDL and secreted. And eventually, this leads to formation of low-density lipoproteins. Now, as you see over here on the right, in patients with fatty liver and NASH, the HMG-CoA reductase and SREBP2 are all increased. And at the same time, when we gave in precision cut biopsies, we exposed labeled substrate, we were able to demonstrate increased triglyceride and cholesterol synthesis. And at the lower right, you see that in NASH, there is an increased accumulation of free cholesterol. So the cholesterol and triglyceride, which are so critical and the central target of atherosclerotic disease, come from the liver. And this is increased in the setting of MASLD. So again, proving biologically that there's a very strong story here that the liver is indeed upstream of cardiovascular disease. Now further, when VLDL is secreted, VLDL triglyceride is removed by peripheral lipoprotein lipase, enriching it with cholesterol and leading to the formation of low-density lipoproteins. Now, when you have put out a lot of triglyceride, the lipoprotein lipase is unable to remove all the triglyceride. And that leads to triglyceride-enriched intermediate density lipoproteins. which are susceptible to hepatic lipases, endothelial lipases as they go through the liver, which cleave them so that for the same amount of cholesterol, you have more LDL particles, and these are called small dense LDL particles. And if you look at the relationship with large VLDL particles with small dense LDL particles, many years ago we showed that these go hand in hand. And furthermore, when you go from lean to obese controls to fatty liver to NASH, you can see that the small dense LDL cholesterol, which is the most atherogenic LDL particle, is progressively increased. And I have already shown you how the biology is linked to the metabolic pathways for lipids in the liver. So to summarize this biological process, what we have shown is that the upstream role of the liver in the genesis of cardiovascular disease is supported by the liver being the source of cholesterol. It's the target of statins. It's the target of PCSK9. It is the source for triglyceride, source for ApoB, C-reactive protein, inflammatory cytokines. For HFpEF, release of lipotoxic lipids, inflammatory cytokines. And for hypertension, it is the source of angiotensinogen. Now, what does this mean for our patients? So there is always a tension between the needs of individual patients versus the needs of society. And that allows us to think about an integrated approach where the liver has to be considered in the context of cardiorenal metabolic disorders and in both risk assessment and developing risk-based strategies. Now, one message that I would really love to leave for everybody here, particularly those who are not liver doctors, is to use this test called FIB4. Is it perfect? No. But it is a test that was originally developed to identify those with advanced fibrosis in the liver in the context of HIV, Hep C co-infection. But we have extensively validated this with data over 100,000 patients at this point, and this is widely now used, and particularly is tremendous prognostic marker for clinical outcomes. So it is widely available, just requires CBC with platelets and a hepatic panel. It is a surrogate for fibrosis, but is not a great surrogate, but it is strongly associated with prognosis. And changes in FIB4 are also linked to changes in prognosis, and they have been linked to outcomes in the general population as well as in populations that are known to be diseased. So FIB4 requires computation of age, AST, ALT, and platelets. And the two numbers you need to remember are 1.3 and 2.6. And what you see here is really that the risk of all-cause death, liver events, MACE, HCC, all increase exponentially as you go from FIB4 below 1.3, where the numbers are like population mean, to a modest increase in the middle when it's between 1.3 and 2.6, and a very dramatic increase when you have a FIB4 over 2.6, because this is a population that is likely to have clinically silent but significant liver disease. This is the population that should be referred to see a gastroenterologist or a hepatologist because the potential future need for cirrhosis. Now, a challenge that we face is how to really evaluate competing risks. So we use this target and basically look at risk on multiple axes, and we can connect the dots to actually get an idea of what is the biggest threat to life, so we can know where we need to pay the most attention for a given patient. And this has already been put in play, and we will publish the outcomes of this later in this year. Of course, as for management, there is Life's Healthy Eat, and there are other ADA has its own set of recommendations, but they all basically are quite similar. Key is weight loss, nutrition, physical activity, mental health, alcohol consumption should all be considered in this setting. Drug therapy is moving very aggressively forward. Many classes of drugs are already in play. In India, you also have saroglitazar, that is available. A major phase 2 trial has been completed in the US and will read out later this year, but already GLP-1s are available. Resmetirom is coming, and then pan-PPARs will read out also by the end of the year. So this is a very, very active field. And by modulation of the liver disease, we hope we will be able to actually reduce the incidence of cardiac, renal, and metabolic disorders. So with that, I will finish by the following key takeaways. I want to highlight that staying alive is really the greatest human safety concern, and that MASLD is part of a larger construct of metabolic health and NCDs and plays a central role in metabolic health. Risk assessment and approach requires consideration of competing risks. A minimum set of labs permit assessment of competing risks. Therapeutics are based on disease stage and relative risks of systemic versus liver outcomes, and this will require care pathways with multidisciplinary approaches in collaboration with obesity medicine, endocrinology, cardiovascular, and family medicine. I thank you for your attention.